Good morning, everyone. In this lecture, we will continue our discussion regarding pneumoconiosis, namely silicosis and asbestos related lung diseases. Then we will discuss important points regarding eosinophil related and smoking related interstitial lung diseases. As we said in the previous lecture, the main and the most common mineral dusts include coal dust, silica, and asbestos. All of them are involved in the development of pneumoconiosis. Silicosis is currently the most prevalent chronic occupational disease in the world. It's caused by inhalation of crystalline silica, mostly in occupational settings. Silica occurs in both crystalline and amorphous forms, but the crystalline forms, including quartz, are more toxic and fibrogenic. Quartz is most commonly implicated in silicosis. Amorphous silica, on the other hand, is less pathogenic, so mostly this disease is related to the crystalline silica and mostly the quartz. And the exposure usually is related to the workplace. So workers involved in sandblasting and hard rock mining are at particular high risk. يعني الناس اللي بيشتغلوا في تعدين الصخور الصلبة أو في المحاجر هدول الناس بتعرضوا لأكثر للكريستالين سيليكا mainly the quartz وهدول الناس أكثر ريسك إنه يصير في عندهم سيليكوسيس. After inhalation, the silica particles interact with the epithelial cells and the macrophages. This results in activation of the inflammasome and the release of inflammatory mediators by the pulmonary macrophages. The inflammatory mediators released from the pulmonary macrophages include interleukin 1, tumor necrotic factor, fibronectin, lipid mediators, oxygen-derived free radicals, and fibrogenic cytokines. The characteristic inflammatory reaction mentioned in the previous slide with the fibrogenic effect and the release of the inflammatory mediator can be minimized when mixing the quartz with other minerals. So the fibrogenic effect of the quartz is reduced. And the good thing that quartz in the workplaces is rarely pure. So the common scenario to have the quartz mixed with other minerals so the fibrogenic effect is reduced. Morphologically, lung silicosis presents as silicotic nodules in the upper zones of the lung. In the early stage, silicotic nodules are tiny, barely palpable, discrete pale to black nodules, especially if the coal dust is present. This figure shows the gross appearance of the lung involved by advanced silicosis. Scarring has contracted the upper lobe into small dark mass. Please look to the yellow arrow. Note the dense pleural thickening. Please look to the blue arrow. Microscopically, the silicotic nodule demonstrates concentrically hyalinized collagen fibers surrounding an amorphous center. The whorled appearance of the collagen fibers is characteristic. Examination of the nodules by polarized microscopy reveals weakly birefringent silica particles in the center of the nodules. As the disease progresses, individual nodules may coalesce into hard collagenous scars, with eventual progression to progressive massive fibrosis. As you may remember from the previous lecture, progressive massive fibrosis is associated with extensive fibrosis and deterioration in the lung function. So it's a generic term that applies to a confluent fibrosing reaction in the lung that can be a complication of any of the pneumoconiosis. So due to the expansion of the nodules and the progression to extensive fibrosis in some cases, the intervening lung parenchyma is compressed or overexpanded. This will result in what we call honeycomb or end-stage lung. Fibrotic lesion can be also seen in the hilar lymph nodes and the pleura. This figure shows the histologic appearance of the silicotic nodule in the lung. As you can appreciate, there are concentrically arranged collagen fibers surrounding an amorphous center. At the periphery, as you can see, the alveolar spaces are still patent. This figure shows another silicotic nodules. Each is composed mainly of bundles of interlacing pale pink collagen. There is a surrounding inflammatory reaction. A greater degree of exposure to silica and increasing length of exposure determine the amount of silicotic nodule formation and the degree of the restrictive lung disease, which is progressive and irreversible. This figure shows silica crystals under the polarized light microscope. The crystals are bright white with variable sizes. Please look to the yellow arrows. So the silica crystals that are inhaled and reach the alveoli are ingested by the macrophages, which secretes cytokines to induce a predominantly fibrogenic response. And because the inorganic matrix of the crystals is never completely digested, this process continues indefinitely and is made worse by repeated exposures to the dusts that contain silica. The result is the production of many scattered nodular foci of collagen deposition in the lung, which we call the silicotic nodules, and eventually restrictive lung disease progressing into cor pulmonale. Clinically, silicosis is usually detected in asymptomatic workers on routine chest radiographs. Chest radiographs show a fine nodularity in the upper zones of the lung. Most patients do not develop shortness of breath until late in the course. After the development of a progressive massive fibrosis, the patients start to experience shortness of breath or dyspnea. Many patients with a progressive massive fibrosis develop pulmonary hypertension and cor pulmonale. The disease is described as slowly progressive, resulting in pulmonary function impairment to a degree that the physical activity is severely limited. Silicosis is associated with an increased susceptibility to tuberculosis. This happens because silicosis is associated with depressed cell-mediated immunity. Furthermore, the crystalline silica inhibits the ability of the pulmonary macrophages to kill the phagocytosed mycobacteria. On the other hand, the relationship between silica and the lung cancer is still unsettled because most studies suggest that silica exposure is associated with some increased risk. However, this topic is still controversial.